Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Mature Results of a Phase 2 Study of Rituximab Therapy for Nodular Lymphocyte Predominant Hodgkin Lymphoma by Advani and colleagues. My name is Jon Arneson, and I am an instructor in medicine and staff physician at Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, Massachusetts. My oncologic specialty is hematologic malignancies and bone marrow transplantation. Nodular lymphocyte predominant Hodgkin lymphoma is a rare subset of Hodgkin lymphoma, accounting for roughly 5% of Hodgkin lymphoma. Given its rarity and the lack of randomized clinical trials, the ideal management of lymphocyte predominant Hodgkin lymphoma continues to be defined. Nodular lymphocyte predominant Hodgkin lymphoma differs from classical Hodgkin lymphoma in several ways. First, it tends to have a more indolent and sometimes prolonged course. Second, the disease expresses CD20. Given these differences, lymphocyte predominant Hodgkin lymphoma does not have a clearly defined treatment paradigm, and treatment options include observation, radiation therapy for localized disease, and combination chemotherapy with or without the addition of rituximab to target CD20. In this study that accompanies this broadcast, Advani and colleagues describe their prospective experience with single-agent rituximab as treatment for lymphocyte predominant Hodgkin lymphoma. Beginning in 1999, patients treated at Stanford University Medical Center and the Washington University Medical Center were enrolled on trial. A diagnosis of measurable nodular lymphocyte predominant Hodgkin lymphoma is confirmed by immunohistochemistry, and the presence of characteristic malignant popcorn cells was required. Patients were required to have adequate organ function to receive treatment and were ineligible if they had received treatment for their lymphoma within the last 4 weeks. Pre-treatment evaluation included imaging with CT, physical exam, baseline laboratory tests, and a bone marrow biopsy. 39 patients were treated. The first 23 patients were treated with rituximab at a dose of 375 milligrams per meter square for 4 weekly doses. Beginning in 2003, a second cohort of 16 patients was treated with rituximab at 375 milligrams per meter squared for 4 weekly doses, and then went on to receive maintenance therapy with 4 weekly doses every 6 months for a total of 2 years. There was a spectrum of different stages of disease in both groups and a wide range of time from diagnosis to initial treatment. All 39 patients were evaluable for response. The overall response rate was 100%, with 67% achieving a CR and 33% a PR. The median progression-free survival for treatment with rituximab was 3 years, and the median progression-free survival for rituximab plus rituximab maintenance was 5.6 years. Treatment was well tolerated with no grade 3 or 4 toxicities. The authors analyzed the previously untreated patients separately and demonstrated that the median progression-free survival was 1.9 years for rituximab alone and 5.6 years for rituximab plus rituximab maintenance, and that the median overall survival has not yet been reached in this group. The two groups had similar 5-year median progression-free survival and overall survival. Interestingly, 29% of patients transformed to an aggressive B-cell lymphoma. The majority of the transformed patients were noted to have abdominal involvement of the lymphoma at enrollment. Results were similar in the previously treated group. Specifically, median progression-free survival was 3.4 years in patients treated with rituximab alone and 6.4 years in patients treated on the maintenance arm. Median overall survival has not yet been reached. In the previously treated group, the estimated 5-year progression-free survival was 36.4% in patients receiving rituximab and 71.4% in patients receiving maintenance. 19% of patients transformed to an aggressive lymphoma. Again, a majority of the transformed patients had abdominal involvement at enrollment. The authors conclude that single-agent rituximab is an effective agent in nodular lymphocyte predominant Hodgkin lymphoma in the upfront and relapse setting. Both the standard and maintenance schedules were well tolerated with no significant toxicity. Despite an initial overall response rate of 100%, a pattern of continued relapse was demonstrated. The authors suggest that given rituximab's significant activity and limited toxicity, it should be considered for patients who cannot tolerate cytotoxic chemotherapy or could be used to delay the use of cytotoxic chemotherapy for select patients. The best primary therapy for nodular lymphocyte predominant Hodgkin lymphoma has not been established. For patients with low-stage disease, radiation therapy with or without chemotherapy has been the standard, with the goal of obtaining long-term disease control. In fact, with this strategy, 10-year progression-free survival can be attained in the majority of early-stage patients. Given the expression of CD20 in lymphocyte predominant Hodgkin lymphoma, the use of rituximab is an attractive option in both early and late-stage disease, and this strategy has been investigated by the German Hodgkin Study Group and at the MD Anderson Cancer Center. The experience we are reporting today fits with prior published reports and demonstrates a good overall response rate, but a continued pattern of relapse over time with single-agent rituximab. Perhaps most concerning, however, is the high incidence of transformation to an aggressive lymphoma following single-agent rituximab. This finding may be consistent with the presence of aggressive clones not targeted by rituximab. The authors made the observation that the majority of transformations occurred in patients with an abdominal component to their disease, and it is possible that patient selection explains the high rate of transformation seen in this trial. While this paper only describes a small number of patients, it clearly demonstrates the efficacy and tolerability of rituximab as treatment for nodular lymphocyte predominant Hodgkin lymphoma. However, given the pattern of continued relapse and high rate of transformation, rituximab as a single agent should not be considered optimal therapy for patients with newly diagnosed disease. The findings suggest a potential role for a single-agent rituximab in patients with relapsed disease or other populations for whom cytotoxic regimens would not be tolerable. The ideal treatment regimen for nodular lymphocyte predominant Hodgkin lymphoma continues to be defined. This paper makes a compelling case for the use of rituximab in future prospective clinical trials, potentially in combination with standard cytotoxic regimens or other targeted therapy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.